entrepreneur, and an educator whose leadership continues to elevate advanced practice nurses. Dr. Michael is a clinical professor at Texas Women's University and the honor of Access Behavioral Care. With over 3 decades in women's health, mental health, and legal nursing consultancy, Dr. Michael has shaped graduate nursing education and simulation-based learning. She's a former president of NINA, INAC, SCTI-DT, Sigma Theta Tau International Delaware Triangle Chapter, and TNA-D4, Texas Nurses Association, District 4, and a mentor through Estetia and Elsevier. Her passion is reducing cervical cancer, advancing mental health and resilience, and empowering nurses through education and mentorship. Next, I'm honored to introduce Dr. Grace Samuel, a visionary in advanced practice leadership and a tireless advocate for culturally responsive care. Dr. Samuel is a primary care provider for house calls, delivering care to underserved and homebound populations. She chairs the APIN committee at AINJ2, American Association of Indian Nurses, New Jersey, Chapter 2, and was named Clinician of the Year 2024-2025. Dr. Samuel is a fierce advocate for community-based innovation, including mobile health and home visits, and is committed to mentoring future MDs and elevating nursing through lifelong learning. Now that I have introduced each of our distinguished panels, let's dive into the heart of today's conversation. We will begin with Liffey Jerian, a seasoned clinical leader. Liffey, in your experience, how are APPs redesigning clinical excellence in high acuity or specialized settings, and what leadership qualities are essential to sustain this transformation?
Thank you, Vinu, for that great question. Good morning, everyone. It is truly an honor to be included in this panel to discuss about transformative power of APPs in healthcare. So, I am a oncology advanced practice provider, clinical nurse specialist, who leads a dynamic team in acute care, clinical trial units, and infusion services in my place. Our work centers on delivering specialized high-quality care to some of the most complex oncology patients who are going through their treatment, and we take care of them who are battling complications related to cancer therapy and also undergoing specialized treatments like bone marrow transplantation and cellular therapies. So today I would like to address this question from the perspective of my work and my specialty. In oncology acute care, a clinical nurse specialist uses the traditional 3 spheres of influence: patient, nurse, and system, to improve care for critically ill cancer patients. So let's start with the patient sphere. In the acute care setting, the complexity of patient needs more than routine care. It requires advanced expertise and precision decision-making. So the APPs have to deliver evidence-based, highly specialized care tailored to complex conditions. Symptom management is one of the mainstays of APP practice in oncology. So the symptoms may be due to complications related to their treatment itself, or progression of disease, or maybe organ dysfunction. So one of the most critical roles we play is being proactive, anticipating complications before they arise and intervening early. Now this approach significantly improves patient outcomes, reduces emergency visits and hospital admissions, which not only benefits patient outcomes, but also reduces the burden on the healthcare system. As part of this, APPs develop and implement protocols for managing pain, nausea, and other organ dysfunctions related to cancer treatment. So now let's look at the nursing practice here. APP serves as mentors, educators, fostering a culture of continuous learning. We implement structured onboarding programs for new nurses and APPs alike, ensuring they have the support and resources needed to succeed in such a specialized and demanding field. Regular clinical case conferences create opportunities to review complex cases, share insights, and promote evidence-based decision-making. Leadership in this context means modeling credibility, clear communication, vision, and accountability. These qualities inspire confidence in our team and help sustain clinical excellence over time. When APPs invest in mentoring and professional growth, they empower the entire nursing team, creating resilience and adaptability that is vital in high-quality settings. So how do we impact the organization at a systems level? APPs are critical drivers of quality improvement and operational efficiency. For example, we initiatives that streamline complex workflows such as chemotherapy privileging processes. We enhance safety and reduce delays in patient care. We also champion interdepartmental collaboration, breaking down silos, ensuring seamless coordination among oncology providers, pharmacy, infusion services, and acute care units. So our role as advocates for system-wide best practices means we help embed improvements that benefit not only individual patients, but the healthcare organization as a whole. So by integrating frontline clinical insights into organizational strategy, APPs ensure that operational changes are practical, effective, and truly patient-centered. So what are the operational qualities that we need to sustain this transformation? Sustaining this transformation advances requires strong leadership. First and foremost, credibility built on clinical expertise is very important. It earns the trust of patients, colleagues, and leadership alike. Visionary leadership helps us anticipate future healthcare needs and innovative new care models that addresses evolving challenges. Effective communication is another cornerstone. Accountability and integrity creates a culture where safety and ethical practice are prioritized every day. Importantly, mentorship and empowerment of colleagues build a foundation for lasting impact. So, as advanced practice providers, we hold a unique and powerful role in transforming healthcare delivery in high-quality and specialized settings. Through advanced clinical expertise, leadership in nursing practice, and system-wide advocacy, we reshape how care is delivered, improving outcomes, strengthening teams, and advancing organizational excellence. Thank you.
Thank you, Luthi, for expertly guiding this panel and spotlighting such a powerful contribution. Your journey reflects how APPs elevate care through precision, foresight, and dynamic excellence. Our next panelist is Dr. Nidya Albuquerque. So let's move from clinical space to academic sphere. Dr. Albuquerque, in your view, what does the future of APP education look like, and how can we ensure it remains responsive to evolving healthcare needs and community goals?
Thank you, Bindu. This is such an important question because we know yesterday we did have a discussion on advocacy and why APPs need to have full practice authority. But my dual role actually places me in a very unique position to offer some insights into the future of this practitioners' education, ensuring that we remain responsive to the evolving healthcare system in the 21st century. Now, for those of you who are in academia, you know that in the spring of 2021, the American College Association of Colleges of Nursing approved and published the Essentials. The Essentials are basically the core competencies for professional practice to guide nursing education in the 21st century. Now, these essentials basically have 10 domains, and each of these domains have core competencies and sub-competencies, and these are evolving around actually spheres, and these spheres are basically across disease prevention, chronic disease management, rehabilitation and restorative care, and also hospice and palliative care during the lifespan of diverse patient population. Now, for us who are NPs or APPs as we call ourselves, NP education is also guided by the standards of NAFPF that is the Nursing Organization of Nurse Faculty Practice, right? And we also have the task force, who have 19 institutions have joined and set the standards for nurse practitioners education, and both of these organizations have embraced the essentials. So where are we going from here? There has been a call for action to move from content-based education to competency-based education. And those of you who are in nursing education or in academia are right now mapping out all the competencies that the programs need to have. So where are we going from here? I listed actually 7 shifts. The first shift is competency first. And the thing is, all of that we learn, but all of that we educate has to be EPA driven. Now, what is EPA? Is entrustable professional activities. Now, we have in the past, based everything on the content. We need to move from traditional methods of time-based credit hours and clinical hours to mastery-based competency, just like the medical students. And use EPA in the forms of real-world scenarios of managing chronic disease condition in clinical settings and also in the community. The second is seamless academic practice pipelines, and this is where we really need to focus. That means there should be a smooth integration between practice and education. We find that the education is in the four walls of institutions, but we need to actually replicate or mimic the medical model and have nurse practitioners ready for practice as soon as they graduate from the NP program. So we need to encourage clinical immersions, not just course completion, but practice ready. We need to be practice ready to be there to serve. The next is precision learning and data and AI. We all know we are moving towards AI, and so there should be boards that are prepared and work towards personalized learning journey for each student. That means ensuring that we have the right learner gets the right support at the right time. Now we have to create dashboards actually, both for faculty and for the students so that they can monitor the progression. The simulation that mirrors model here, using high fidelity models so that we can simulate practice scenarios in the classroom setting so that they can go and be ready for practice. Encourage interprofessional simulation technology, so including telehealth and AI-driven monitoring chronic disease conditions. Now the next one is population health and value-based care. It needs to be baked in. What does that mean? This can be done through curriculum change, that means integration, teach students to assess both individual and population level needs, include preventive care and social determinants of health. We've all heard about it. SODs need to be, should be data driven, and these should have access to data. They should be able to have access to registries so that they can plan their care. Regulatory literacy and advocacy, most of us are familiar with some regulatory literacy and advocacy, and we heard a lot about advocacy yesterday. I'll be speaking a little about it in my next question, but regulatory is to know the practice laws so that we do not get ourselves engaged in any lawsuits or malpractice, with patient population. Then we also need to do equity as design principle, not as an add-on. We heard the speaker today this morning talking about equity. So equity should be practiced right in the curriculum. So the equity in curriculum is basically making sure that the curriculum is designed to fit in all cultures within and teach cultural humility to students right from the beginning of the MP program. Right? So these are the things that we really need to make sure that we are advocating to make the change in the next 21st century. Thank you.
Thank you, Dr. Albuquerque, for advancing the evolving landscape of MP education. Now, let's look at how innovation extends beyond institution into the entrepreneurial world. Dr. Jackie Michael is an entrepreneur. So, Dr. Michael, in what ways are APPs driving innovation through entrepreneurship, and what barriers must
practice. I'm an APRN, certified as a women's health. Got way back in 1993, 33 years of running that practice. And then did a second certification as a psych mental health NP. So my women's health practice is ongoing as colposcopy, and my psych is actually taking active energy and engagement. From that, I also want to give you another perspective of my professional life, which is a legal nurse consultant. I do find merit in cases I review. Then the attorneys take it from there and decide if they can settle outside the court or take it back to the court. And the third hat I wear as entrepreneur, because I sell myself and my services for my own profit. And that is to be a curriculum designer. As you have heard several educators talk, including Dr. Albuquerque, that we are going through a CCNE revamping of competency-based curriculum. Outcomes are being mapped, and traditional educators are looking for somewhat intermediary educators like myself who come from the old school, who understand the new, to make the bridge between the two, so that curricular redesign can happen. That said, I do all of this for my personal gain. Therefore, I am a small business owner. I do 1099 services, and I can talk to you guys more about it in one of the breaks. I had to think how I was going to design my practice for it to be a PLLC, under which I was going to have individual businesses as LLC, and then how to protect them. So more about that as we go on. But the question that was asked is, how do I keep it scalable? How do I keep it sustainable? And how do I move forward? And perfect. Okay, so I'm continuously scanning the horizon. I'm looking for challenges, because in those challenges, I find opportunities. I'm defining my niche. If everybody's doing blood pressure management, what is the chance I'm going to get 1 out of 25 competitor business? So I, as a women's health NP, have a colposcopy or dysplasia practice. Not everybody's certified as a women's health NP in that. I do consulting, I do education, and it meets very well with my goals and my mission statement of promoting cervical cancer prevention and serving women. So you have to keep it all aligned so you can get the best bang for your efforts. Then the other thing that I do is resilience. Actually, I got turned on to resilience during COVID. Then I got a grant, and I learned the merit of resilience. And I thought, I'm going to bring it in a formal way in my practice. So I did, and went back to school, way into my 50s, to become a psych mental health NP. So as a psych mental health NP, my practice is in North Dallas. It's a very chichi area, very sophisticated area, and everybody needs medication for anxiety and mood to get through life, to serve on PTA boards and just be a mom and a wife. So that is what I do. So I use that to do a Robin Hood practice, because my other goal is to provide pro bono care to first-generation immigrants, to provide it for my daughter as a minister, so when she brings some refugees who are needing PTSD treatment and don't have funds, I use profit-based practice to offload it. So I'm continuously looking for opportunities so that I can stay profitable and sustainable. But in the end, and in the very beginning, the mindset is to excel at all costs. That said, I am removing barriers to access of care by having competitive rates. I'm on a lot of commercial plans. I'm a savvy utilizer of technology and information. I use AI, I use virtual assistants to help me. I have cutting-edge EHR that ensures safety for my patients. I do my own accounting and billing, so I don't have to do profit sharing by subleasing those services. In the end, presence is important to me. Image is important to me. I have to continuously think outside the box. I'm looking at performance and the infrastructure for my practice. Being mindful of what the regulatory practices are, so And then legal considerations. I'm a legal nurse consultant. I don't want to be my own client and do something that I should not do. So continuously, our rule in Texas is Regulation 221. I literally have all the lessons memorized. So I don't do anything I advise others not to do. Branding is important. In other words, what am I synonymous with? Advocacy is important. What am I positioning myself to have a voice for? And legacy is important. How will I be remembered when all is said and done? So maintain a laser-sharp focus, set your mindset to excel at all costs, scan the horizon, be competitive, be savvy, think outside the box, and stand out to outdo the competition. Thank you.
Thank you, Dr. Michael, for spotlighting how APPs can drive transformative, tech-enabled ventures that expand access, close care gaps, and lead boldly beyond the bedside. Thank you so much for sharing. Now we'll turn to a community-centered behavior innovator, Dr. Grace Samuel. How can APPs build trust and deliver culturally responsive care in underserved communities, and what models are probably most effective?
Thank you, Dr. Shantipur. That's a great question, and it really speaks to how combined advanced practice providers play such a vital role in addressing health inequities. Here are some of the ways to provide culturally responsive care. Advanced practice providers establish trust by actively listening and being involved in the care of patients and their communities. It is more than just treating illness, it's about partnering in health. Consistently showing up in community spaces, building presence in neighborhoods, churches, and schools, listening and creating solutions, help engage communities in shaping programs and interventions, inviting feedback to advisory groups or community forums. Be respectful of culture and language. Provide interpreters, multilingual resources, and culturally tailored health education. Practice cultural humility, not just cultural competence. Building long-term relationships, continuity of care, and follow-through demonstrate commitment which fosters trust and improves adherence. Whole person needs must be addressed by incorporating social determinants of health, such as food, housing, and transportation, into care planning and connecting with social resources to meet these needs. Partner with community health workers, collaborate with trusted messengers from the community who build cultural understanding and extend the reach of advanced practice providers. Lead by example.
So basically, advocacy is changing the rules, and regulatory is basically knowing the rules, right? So what you saw me demonstrate yesterday with Smith Pandey is basically I was trying to advocate for full practice authority, correct? And we went into a discussion and the other side of the party was just very resistant, saying that the education is not at par. Well, that is being the voice for your own practice. You need to be the voices, whether you are an APP, whether you are a nurse, whether you are a nurse manager, wherever you are, you need to be the voice. And the voice for APPs is basically through the American Association of Nurse Practitioners. You heard us people in the morning talking about AANP. So AANP is doing a lot of work towards advocacy, and if you visit the AANP Advocacy Center at the AANP website, there are policy papers, actually there are position statements, there are white papers, and there are some of the requests for it to be changed into a law, and so that some changes be put forward. So you as APPs or you as nurses need to be very informed of the advocacy portion in how you can impact and bring the change. Now advocacy occurs at your own level, that when you're advocating for your patient. It happens at state level and it also happens at federal level. So be part of it, be the voice, learn more, and I think we can be the voice for change because UHSC is moving towards full practice authority, but we are not still there, whereas some of the states are. So that is advocacy, is talking for yourself and being the voice for yourself. Thank you.
Thank you for championing the power of advocacy in shaping our practice. That is a powerful call for action. So if you are passionate about shaping the future of healthcare, don't miss the 2026 AANP Health Policy Conference in Washington, D.C. from February 8th to 10th. And earn up to 16.5 credits while learning directly from policy leaders and building your advocacy toolkit. Register before the space fills up. So before we close, let's do a quick round of takeaways. A powerful message for our audience from our panelists. Whether it's a call to action, a guiding principle, or a personal insight. What's the one thing you want everyone to walk away with today? First, I'll start with you.
That resonates with my core values. Embrace integrity, excellence, and lead with honesty, and also have a passion for excellence and patient-centered care. That's what I do in my work.
Thank you. And
So for me, is the call to action is be a mentor and mentor as many as you can to the next generation of APP practice.
Thank you. Yes.
At the same time, I'm ready to go. It's like a race. You should know where you're going, and then you need to chalk out the shortest and the funnest way to get there. It's like any other journey, you only have one life, make the best of it, think outside the box, and champion what is dear to you and your heart. You will be most familiar with it.
Thank you, Dr. Michael, and finally, Dr. Grace.
Practice cultural humility, not just cultural competence.
Thank you. So today's discussion reminds us that APPs are not just providers, they are architects of change. Whether through clinical innovation, educational reform, entrepreneurial ventures, or policy advocacy, APPs are shaping a future that is equitable, responsive, and resilient. So let's carry this energy forward into our practice, into our partnership, and our purpose. So before we close, I would like to welcome a few questions if you have any.
I think I've seen many transition to practice programs for ACPs. I think around the country now accredited 300 by ASCC. But still we are struggling for transition to practice, right? That's the reason we're struggling to patch up the problem by adding PTAB programs to like Nurse Residency program or even APP program. But we are now correcting the original issue
compare PA versus APP. So I just wanted to ask, what is coming up now to change that?
Okay, so I do this consulting. I go and meet community partners, the systems leaders who are hiring our graduates, and I ask them, what is the gap that is there? And that should be the graduation check mark before that student walks out. I have instituted a passport that the UTA students take with them with a CD, and they are hired right away because they carry with them skills that they have competency documented on. They take with them how many hours of clinical they have completed, the diagnosis they have that they have taken care of, and the medications they're proficient in managing at a student NP level. And that is getting them hired. Our UTA, now I'm retired from there, hire rate was 98.7%. So they're sought after. So we have to bridge the gap.
I think what we need to hit right away is to move to competency-based education and change the way we teach GPs. It's not completing the courses, it's not completing their hours, but it is making sure that they are competent before they transition into real-world practice. There is a policy that we do not require residency programs for APPs, although some hospitals are providing, but that should be the goal, right? So that's where we are moving. The shift that I discussed is that's where we need to focus and we need to move to.
One more thing. Many of you all are serving as preceptors. You know the practice and you know the gap. Make sure you emphasize that to students.
And I would also add is, we are all, faculty is living in a cycle. Like, faculty are in the four walls of academia and universities and they don't have real world clinical practice. That has to happen. Faculty should be just the way the doctors are. We need to be moving towards clinical practice, take our students with us, measure, monitor them. So that type of changes have to take place and that's where we are moving. Universities have to, like medical schools have to embrace a practice environment. And if that happens, there will be the gap, we'll be able to bridge that gap better. Because we don't want faculty members only to sit in the universities and read peer-reviewed journals and, do things like that and then translate it to the students. I really don't know what is happening in clinical practice. I work clinically 1 day a week or 2 days a week, and that should be the practice.
Thank you. Just
So I'm thinking the gap for bridge to practice, what Simi was mentioning, how about a residency program after the nurse practitioner course?
So let me answer that. Very good question. But if you go to the AMD website and look at the policies and the white statements and stuff, things like that, we need to demonstrate that we understand that the medical schools, they have residency program. Their model of education is slightly different from what we do. We are moving towards having as practitioners graduate with all competencies. If some organizations want to offer that, the residency program, it's up to the organization, but it cannot be mandatory because we want to have APPs who are ready to go out into the world and do what they need to do. So that's what is the practice right now.
thank you so much for all the panelists. In the interest of time, we have to end this session here, but if I know we have a lot of questions, our panelists are available to answer your questions in person, so please reach out to them. And thank you all for your attention.
I'm Dr. Manju Samuel. I'm the education chair for NINA. This year we have the theme as Engage, Educate, and Empower, Advancing Nursing Excellence through Practice, Leadership, and Innovation.
Hello, my name is Suki Sangha. I'm the ANCC director for NANA. We had a gathering of many, many individuals that came as advanced practice providers, nurses at the bedside, managers, and leaders in the organizations.
Next, we have a clinical session talk by Dr. Taluka, and concurrently, we have a panel discussion on the topic Mental Health and Substance Abuse Prevention for South Asian Indians. So those who want to join the clinical session with Dr. Taluka can stay here in this room, and the others can go to room R4. Now I request the panelists, Dr. Rani Kaplan, Dr. Jin Stasha, Dr. Ann Lucas, and Nini Tom to lead the other room with their panel discussion. Now I invite Piano's Aviana Chair, Dr. Lita Joseph, to introduce our clinical session speaker.
Good morning, everyone. So I'm Lina Joseph. I'm Aviana Chair for Piano. So today, it's an honor and a great privilege for me to introduce someone I not only admire professionally, but also personally look up to, Dr. Alex Hector. Dr. Taluka is the Associate Chief of Cardiac Surgery for Einstein Health Network and is dual board certified in both thoracic and general surgery by the American Board of Thoracic Surgery. She's highly regarded for her expertise in minimally invasive valve procedures and aortic aneurysm heart surgery, as well as in complex preoperative valvular procedures and adult feminine cardiac surgeries. Her outstanding contribution to the field have been widely recognized. In 2016, she was honored as a Pennsylvania top physician under 40 by the Pennsylvania Medical Society, and she has consistently been named a Castle County top doctor. Beyond her clinical excellence, she is a dedicated leader and active member of the Society of Thoracic Surgeons, Women in Thoracic Surgery, and a fellow of the American College of Surgeons. I have had the privilege of witnessing her firsthand, her passion, her compassion, her commitment to excellence, and the inspiration she brings to those around her. It is truly a special honor to welcome her here today. Please join me in giving a warm welcome to Dr. Taluka.
Thank you so much for having me. It really is an honor. I know some of you, and I know that I've been in the Philadelphia area for 11 years now as a cardiac surgery attending, and I've worked with some of you, and it's just a great opportunity to see everyone. And I hope to make this somewhat practical. I definitely don't want to stand in the way of lunch, and also interactive, so please you can interrupt and ask questions. That's totally fine. I think the first thing I really would want to talk about is just a brief overview. But the most important one, I believe, and this is where a lot of you come in, is the role of the heart. This would be you can see this is a pretty standard, what we call posterior leaflet prolapse on the right side of the screen. You can see there's a little piece of tissue that's flickering. This is I like to call it 4D TE because it's the 3D model with motion. And then to the screen right is the repair. And you can see there's a ring, and this particular one was a ring with cords repair. And this is the echo view. You can see there's really no mitral regurgitation. This would be the intraoperative view and the incision. So again, a really nice and elegant operation in the right patient. That I think there are a lot of adjunct therapies in this space. To
mitral procedures, that was of initial trials. More trials were there for the mitral. But tricuspid procedures were approved in FDA before the mitral. And what's your take on that? How did that happen?
And in these patients, like the complete transcatheter mitral valve replacement. And the lesson that we have in our experience is that if you leave with moderate MR, the recurrence rate is much higher. We try to leave with 1+. I think the ischemic MRs that are the just simple P3 restriction, and you really get that one, and they have choice MR at the end, they're probably not going to recur because the infarct has already happened. They don't have a dilated cardiomyopathy, but the dilated cardiomyopathy patients, they will recur. Because really, as I tell all my patients, I'm like, the final therapy for what you have is heart transplant. And not all of them make it.
Structural heart disease is looked at Israel Center in New Jersey. We have all the procedures that you have spoken about. One of my concerns is that there is a valvular leak. And these patients come back symptomatic. What is the alternative treatment for them? I know it's like
In the area,
yes,
I think we see it more in TAVR. I can't say we've seen it a lot in cerebral valves, at least in the last decade or more. The patients that, I mean, we treat it, we plug them. That's the short answer. The short answer is if the problem is the heart team doesn't follow these patients past a year, right? Like you see the patient, you do the procedure, you see them in 30 days, you see them at a year, and that's the end of the registry requirements, and then they go back to the community. And we have to do a better job at educating our community and referring doctors that if they start seeing AI or they start seeing an increasing gradient over 20, they really need to refer those patients back for evaluation because they might have early prostatic valve degeneration, or they might have a large valve leak, or they might have thrombosed their valve and the AI is not from PPO. But to shortly answer your question is if they're symptomatic with a cardiovascular leak, we plug in. If that doesn't work, they get surgery.
Thank you, Dr. Alexander Taluka, for your inspirational and informational session. Now I invite